So with that, let me turn to Sarah Zanton to moderate the first session. Sarah is a member of the Planning Committee for the workshop and is the Health Equity and Social Justice Endowed Professor and Director for the Center for Innovative Care and Aging at Johns Hopkins School of Nursing. She also holds an appointment in the Department of Health Policy and Management at the School of Public Health. Let me turn it to you, Sarah.
Recording in progress.
Thank you so much. It's such a pleasure to be with you all today, and thanks for the nice introduction. As Maya mentioned, we will be focusing now on the transformation levers, and we'll discuss federal and state regulatory and legal levers that can be used and transformed to advance integrated financing. So I'll introduce all three speakers, and then they will each present sequentially for 10 minutes. So first, we're delighted to have Sue Birch. She is the director of the Washington State Healthcare Authority, the state's largest healthcare purchaser. She was appointed by Governor Jay Inslee in January 2018. She oversees efforts to transform the healthcare system, helping ensure Washington residents have access to high-quality, affordable healthcare. Second will be Dr. Neil Halfon. He's the director of the UCLA Center for Healthier Children, Families, and Communities, and also directs the Child and Family Health Leadership and Training Program at the UCLA Fielding School of Public Health. For more than 2 decades, he has been instrumental in advancing research, policy, and systems innovations focused on the healthy development of children at local, national, and international levels. And our third presenter will be Alex Briscoe. He is the principal of the California Children's Trust and the former director of the Alameda County Healthcare Service Agency. He has designed and administered a number of mental health and physical health programs and services in child serving systems, including home visiting programs, programs for medically fragile children, and clinical and development programs in child welfare, juvenile justice, and early childhood settings. So go ahead, Sue Birch.
Thank you, Sarah. Hi to everybody. I'm Sue Birch. I'm an executive nurse and the director of the Washington State Healthcare Authority, or we call ourselves HCA. Thank you to the National Academy of Medicine. I'm so honored and truly humbled by the invitation and opportunity to present on this distinguished workshop and on this panel with national health experts. HCA is the state agency that purchases care for more than 2.7 million Washingtonians. These include our Medicaid enrollees, our public employees, and school employees. And it makes us the largest purchaser of care in Washington state. We have about 7.5 million that live in the state. We also administer the Compact of Free Association, COFA Islander program, and recently we stood up the Public Option program available through the Health Benefits Exchange. So we spend anywhere between 12 and 14 billion annually, and we take our stewardship of these public resources very seriously. Today, I want to talk about HCA's transformation and business process redesign efforts. Next, I'll outline our success and challenges, and then offer recommendations necessary to take transformation to the next level to achieve a truly integrated healthcare delivery and financing system. So if you'll go to the next slide, please. So not only is HCA Washington State's largest purchaser, but HCA is also a national leader in value-based purchasing, delivery system reform, and innovation and affordability. HCA's ValueBased Journey started in 2013, and it was enabled by state legislation and accompanied by a lot of federal support and resources. We began the long, arduous transformation journey. Over the years, models have evolved and matured, with more recent efforts driving towards more holistic care, paying for population health. And we've taken advantage of state legislative, gubernatorial, and regulatory levers at our disposal to be authorized and to implement these innovations. Now, some examples of this are accelerating the value-based purchasing in our own books of business and financially integrating physical and behavioral health under the Medicaid managed care. We've also developed and implemented an innovative hepatitis C value-based purchasing model with AbbVie. And we've created and implemented a public option program offered on the Washington Health Benefit Exchange. It's the first of its kind in the nation, and it includes cost benchmarks to Medicare, a primary care spending floor compared to Medicare, and quality and value components that align with all of our work. Through legislation, we've created and launched a cost transparency board to move the entire market towards tempering the total costs of care. And it's very important that we continue on that effort so that we can do redistribution of resources into population health needs. In addition to these state levers and federal support and assistance and partnership opportunities, all of these things have been critical to our success. But in addition, we also took great advantage of the state innovation model design and test grants totaling over $66 million through 2019. And that developed 4 payment models and built necessary infrastructure to support care redesign. We've also been very successful with dual eligible shared savings, the Medicare alternative payment model partnership opportunity, which has steadily yielded dividends back to the state's general funds coffers. Also, the dual eligibles, the 1115 waiver for broad Medicaid delivery system reform incentive program, which has been critical to our success. And I'll talk a little bit more about that. Let's move to the next slide. So HCA vision towards healthier Washington has really become more clear since 2014. Our transformation goals have been to strengthen the integration of physical and behavioral health and drive to bidirectionality. And that is a very long journey that needs to continue to be tended. And obviously with COVID, we just have all sorts of new work to keep strengthening on that integration. Secondly, it's a move away from fee-for-service and towards value-based care and affordability, strengthening access and modernizing incentives, and building healthier communities through clinical and community linkages. And while our goals remain the same, our focus recently has pivoted to align with Medicare and CMMI's interests. Now, we're still focused on all of these efforts in a life stage approach, but we have to also back up because of COVID and really strengthen and focus on health IT. Go ahead to the next slide. So we've had a lot of success with value-based purchasing and incentivizing care redesign with the assistance of those state levers and federal support and resources through the SIM and the waiver. And our guiding principles throughout for value-based purchasing, and they are articulated very clearly in our annual VBP roadmap. We align with Medicare as much as possible. We drive standardization and care transformation based on evidence. We align payment and delivery approaches with other purchasers. And we continually strive for lower costs, better outcomes, and better consumer and provider experience. We also reward improved performance of HCA's Medicaid, PEB, and SEB health plans and their contracted health system partners. And we're increasing the long-term financial stability of the state health program. As of 2019, 62% of our healthcare spend are in VBP contracts. That's defined as 2C through 4B in the land framework. All our contracts with our payers have some level of clinical and financial accountability. We also have 4 direct contracts with providers, one with the federally qualified health clinics, the ACO programs, and 2 centers of excellence program. It's still early, but we've achieved great success in shared savings with Medicare on the Duals project. We've also regionalized Medicaid purchasing and built 9 accountable communities of health to bridge medical and community care through our community-based partnerships through a 1115 waiver. So there are a few challenges, and then I'll finish up here. We've learned a lot. Our VBP strategies are driven by the power of financing, and that is a really important thing to play to. At this point, we haven't figured out how to reinvest the savings from the traditional healthcare system to support population health and prevention, but we're having all sorts of conversations and moving upstream. We're thankful to our federal partners now really getting back into the transformation journey with us, and we look forward to that strengthening partnership. And health and healthcare are big sectors at the state and federal level social and healthcare programs, which are very siloed, and we keep trying to figure out the linkage and realignment with USDA, the HRSA programs, and all of our other federal funding partners, the Department of Labor and Commerce in particular. So lastly, I'll just say, if you'll move to the next slide, we're taking transformation to the next level. The bottom line is we need a paradigm shift to truly achieve and pay for population health on a broad scale statewide. And here are our observations and recommendations to transform population health and truly integrate and finance healthcare and social care needs. First, we need that federal government partnership through Medicare and Medicaid to be the first movers. They've got to be the beacon to keep developing national frameworks and strategies, and things like updating the land framework to capture social needs, reflecting the role of the social determinants in purchasing strategies, really important. Modernizing the network adequacy rules, a greater push for strongly incentivizing those carrots and sticks, all providers to participate in value-based models, stronger multi-payer movements and alignment, guidance on building and transitioning social investments, really important, and flexibility to pay for social determinant of health services into current health plan agreements, and also all those workforce barriers. So I'll just say that we also know that we need to increase and strengthen cross-agency system-based coordination in our own state systems. That's really, really hard work. And we have to help the states break out of their health silos. And then workforce. Workforce is the other thing that I think for now 4 to 6 years we've left untended. And we need workforce innovations and more federal support and resources on creating workforces, teams of the future. Less barriers to licensing and non-traditional providers. We have to help small providers in behavioral health with the transformation journey. It's pretty overwhelming for them. And to ensure success, we've got to link all of this to a foundational health IT environment that really delivers on value-based models. So thank you, and I think I will end there and turn it back to Sarah.
Thank you so much. Now for Dr. Halfon.
Hi, and thank you very much, Neil Halfon. And I first want to just apologize that I'm not going to be using slides today for several reasons, most of which was I had a major surgery on my shoulder last Tuesday, so I missed the first meeting. I'm in a sling now and stuff. So it was my second day off narcotics, so you're going to be hearing this a little bit off the cuff. So in terms of strategies and moving forward, the kinds of transformational changes that have been discussed in the last 2 sessions. One is to adopt a framework that allows to overcome fragmentation and really build the kind of integration by design that's necessary, because population health won't happen unless we design systems. So it's really population health equity by design. One of those frameworks is using a life course health development framework. There's been a revolution in health sciences over the last 20 years that tell us that almost all of the long-term chronic health problems that we see and that are very costly, most of them start early in life, or in childhood, and we are sort of missing the boat in the fact that we have all these opportunities to not only prevent, but to promote optimal health development in children, which we're not doing. Severely underinvest then and miss that opportunity. The second framework that I think is really important in terms of holding up and looking towards the future is really thinking about the difference between reform and transformation, and using a transformation framework and some kind of foresighting ability to sort of say, this is the kind of way that we want to move forward. The framework that I find most both appealing and explanatory and easy for people to understand is something called the 3 Horizon framework. And that 3 Horizon framework suggests that you always have 3 horizons in front of you. The first horizon is the current system, leads you mostly to incremental reforms. The third horizon is the transformation or transformed system, and that requires transformative kinds of innovation. In between, you have the second horizon, which are the disruptive changes and innovations that need to take place. I think in putting this strategy together, oftentimes we keep resorting to incremental changes that just keep reinforcing current patterns rather than the disruptive changes that'll lead into the kind of changes in the future that we want to get to. The third framework that I've used and developed with Peter Long and others is something called the 3.0 transformation framework. And what that suggests is that there's a destination we want to get to. We're not just transforming and reforming just for the sake of it, but we'd like to see a health system that looks and has certain kinds of characteristics that addresses people in a holistic way, and a lot of the vision that was laid out. So I think first off that we really need different kinds of frameworks that help us both think about how we move forward, have a destination, and provide the design principles that we need to integrate and organize care in different ways. The second where this leads is towards a whole set of transformation strategies. One of the most important is to think not just about inside out transformation strategies, which are those that the healthcare system sort of develops and then promotes in communities, because what we know that is that health is produced not in hospitals. Hospitals are really for repair. Health is produced in homes and in communities. And so that we can either do the inside out strategies where the healthcare systems are creating all kinds of services, bringing them out to the communities, or create an outside in strategy where you're actually working in communities to transform how they function and organize and move forward. Accountable health communities is one way that that's being done. The CACHI initiative in California is trying to drive that kind of process forward. We're also doing something in California and Cincinnati and other places called All Children Thrive. All Children Thrive is an attempt to move towards a 3.0 health system, move from healthcare to a health system for children. And it's a way of engaging cities in whole child, whole family, whole community of approaches, and helping cities reorganize themselves to move forward. City of Cincinnati and Cincinnati Children's Hospital has been a vanguard place moving this kind of an approach forward. Similar efforts actually going on in Columbus, Ohio, Nationwide Children's, where really innovative ways are being used to engage whole communities to move systems forward. These outside-in strategies are very different because what they're doing is really sort of understanding, organizing, addressing social determinants, not each individually by themselves, but really coming up with a coherent strategy. California now, a state legislature initially allocated $10 million for us to begin enrolling All Children Thrive cities in California. We currently have 25 cities that have become engaged in the All Children Thrive effort, and the legislature looks like it's about to put another 25 million in for the next 5 years to expand this to 80 to 100 cities in California. But this is a population-wide approach to transform the social determinants on wholesale basis in communities to reorganize from an outside in. The third strategy that I will advocate for is a different kind of fiscal tools. Right now, we try to run the entire healthcare system on a one-year insurance contract. And what that does is that fiscal tool doesn't align with either our clinical goals, population health goals that are long-term and more holistic, and because it was never designed to fund and achieve those goals. And so it would be like running the housing market or housing area on a one-year mortgage. And we know that that doesn't fit with sort of family or financial goals. So we need to come up with a whole set of new tools that allow us to invest in the human health capital and health development of children, families, and moving forward. These include things like different kinds of bundled payments bundles that begin to bundle across the lifespan. So imagine a bundle that had continuous eligibility for Medicaid from birth to age 5, that also included early care and education services, social support, and other kinds of things, and was given to a city, that bundle, as a global budget, so that they could organize the services in ways that would move forward. That bundled payment idea would be part of a new set of alternative payment models. I think we're all familiar with alternative payment models 1, 2, 3, and 4 that were designed purposefully to move from the fragmented fee-for-service kind of practice towards ACOs. That was the real goal of the Obama administration and CMMI during that first administration. But we need APMs that move beyond just getting us to ACOs and actually move us towards accountable health community, all children thrive communities. And those are all alternative payment models that Nathaniel Counts and I have been terming alternative payment models 5, 6, 7, and 8 that overcome really important barriers that we have towards long-term or a different way of financing. And those barriers are really important for us to address. I think we all know most of them, but one is the wrong pocket issue, because you can't get horizontal integration in a health system and overcome fragmentation if in fact you can't pay across sectors and organize horizontally. The second challenge is the long pocket issue, and I was talking about that a bit when I was talking about the life course bundle for young children, but you need to have funding that actually isn't on a 1-year contract, but actually is thinking over 5, 10, and 15 years, and thinking not just about expenditures, but investments. The third is moving from clinical populations to geographic populations. And the fourth is figuring out how you cut cities and other geopolitical units into the health development and investment game so that they can be part of the kind of financial investments that are going to be necessary to actually transform what goes on. So my 3 off-the-cuff kind of suggestions is having the right framework so that you can design your way forward and actually see where you want to get to and what that looks like in a transformative way. Come up with strategies like outside-in strategies that are actually multi-solving strategies that begin to organize what we euphemistically call the social determinants of health, and move from social service system strategies to actually ecosystem strategies for optimizing healthy development and well-being. And third is to develop a new set of fiscal tools and alternative payment mechanisms that allow us to overcome these really important long pocket, wrong pocket, and other barriers that make it almost impossible for us to overcome the fragmentation and really lead to real integration. And real integration is not just vertical integration around a continuum of need or severity, but horizontal integration for the whole person, but the longitudinal integration that Life Course informed, so that we're actually aiming at long-term healthy trajectories for people. Thanks.
Wonderful. Thank you so much. And now we'll turn to Alex Briscoe.
Good afternoon, everybody. So I once had a mentor who told me we're all best when we act on the exhale. So I'm going to take a breath out, because in the next 8 minutes, I'm going to move really quick through some things that I hope make you really uncomfortable. Next slide. Something's going on with kids. I'm going to give you some data. If you have a kid or you know a kid, you're probably concerned with their social and emotional health right now. I want to quickly explain the institutionalized fragmentation of California's Medicaid system, both the challenges and opportunities it represents. I want to cite the extraordinary opportunity that the Medicaid entitlement offers us, provide a framework for solutions, and then end with 4 specific strategies that we're using to transform the social and emotional health of children, focused on anti-racism and the impacts of poverty on the health and welfare of children. Next slide. I can tell you these data points, but basically the key one here is something is popping with kids and it's not the water. Between 2007 and 2017, literally twice as many children were admitted to our general acute care facilities for self-injury or suicide attempt. Children told us directly when we asked them, a 61% increase through the California Healthy Kids Survey. And in California, we have the world's largest Medicaid, the nation's largest Medicaid program for children, and by any standard measure, among the worst. Next slide. And as California is also home for income inequality, with the rolling in of our SCHIP program in 2015, Medicaid covers now well over half, almost 60% of all children in the state. We anticipate by September that 6 out of 10 of all children will be covered by Medicaid's program. In fact, 96% of all children in California will now be covered by a health plan with a defined mental health benefit. And tee up the next slide, which you probably will know what I'm about to say. Next, COVID made a crisis that pre-existed COVID much worse. So we now have whatever you call a crisis that you pour a bunch of gasoline on and light on fire. And if you take nothing else from what I'm about to say, I hope you take from this presentation a need for us to reimagine children's behavioral health as something more than a response to pathology. It must be reimagined as a support for healthy development, infused with the principles of anti-racism and anti-poverty. Rady's Children's in San Diego has shown a 1,700% increase in emergency department utilization, and I'm sure you're familiar with the CDC data on the left of the slide. Next slide, please. You cannot talk about this without discussing the impact of structural racism. The data I showed, we could literally spend the next 5 days talking about the root causes. Is it social media available on mobile platforms in 2009? Is it a perpetual news cycle that inappropriately confronts children with images of sexual violence and school shootings? Is it a culture that equates wealth with value and fame with merit? Is it 400 years of structural inequality? The answer is it's all of those things. But young people are telling us that it is a uniquely difficult time to be a child, and you must apply and disaggregate that data by race or you are not understanding it. Reimagining children's mental health isn't a matter of tweaking programs or defining new payment models. It requires an acknowledgement for us as a culture that children are growing up in the context of structural barriers, and preparing and supporting them to manage them is an essential tool of the healthcare, essential strategy of the healthcare system. I have literally billed billions of dollars of mental health services to children across every child serving system. 90% of the kids I served weren't mentally ill, though I had to diagnose every single one of them to get paid. The inappropriate pathologizing of poor people of color is the impact our healthcare system is currently making on young people. 10% of kids did need medication and support of structural therapeutic interventions. The vast majority were presenting with symptomatology due to the fact that they were brown and black and living in a culture that told them they weren't worth nothing. Next slide. Please click through these. I hate presenting this slide because I'm ashamed to live in California. We rank 44th in the nation in access for children. But here's the opportunity. I don't need to tell anyone here that Medicaid for children is a unique entitlement. Sarah Rosenbaum's awesome paper about the national security origins of EPSDT should be required reading for anyone interested in the impacts of children. Next slide, please. You can go ahead. But to distill for some experts on the call, every single Medicaid expenditure is made up of these 2 parts, a federal and a non-federal. Here are the formal definitions. Seems pretty simple, right? If you put up $1 and follow the rules, the feds have to say yes. So how come we suck so bad? Next slide. That federal dollar in California flows through the state, and how it gets to children and families is unfortunately institutionally fragmented through 7 different mechanisms. California is still on a movement towards MCO adoption. Despite our early adopter status, we still have mostly the remnants of a hard carve out between managed care organizations and county mental health plans, but we've diffused the accountability for social and emotional health of children across these 7 different payment systems. And in the chat, we will post a link to a Meeting the Moment paper we just recently wrote, which tells the winding history of the EPSDT entitlement in California. Next slide. At the Trust, we developed a framework for solutions. The Trust is a 7-year initiative designed to reimagine our approach to supporting the social and emotional health of children. We are at the end of year 3. This is our framework. All of our work falls into this mechanism of spending significantly more, of expanding access and participation, of reinventing systems, all based on the principles of equity and justice. You can distill our framework to this following statement. We believe that the children's mental health system must shift agency and power. Agency defined by who does the work, power defined by who gets paid. Next slide. Delightfully, I will be spending the next 2 weeks defending a $4.4 billion youth mental health proposal from the state. It's an extraordinary and transformative moment. Combined with the submission of our 1915B and 1115 waivers, we are transforming as a state in California our children's mental health system built based on the principles that you can't treat away the challenges that young people face. Next slide. This is my final slide, and I just wanted to quickly name the 4 essential levers that we are pulling right now in California to try to reimagine children's mental health as an anti-racist support for healthy development, not a response to pathology. The first is we are formally removing diagnosis as a prerequisite for care consistent with the EPSDT entitlement. You don't have to have measles to get an MMR shot. You shouldn't have to have a diagnosis to get support. This is true both in the new family therapy benefit and our 1915B submission that goes to the feds this summer. We are activating our managed care organizations who until 2015 had no obligation for mental health, now have a new benefit. And we are directly incentivizing them to invest in schools. Children represent 43% of all enrollees, less than 14% of all expenditures. Health plans will not concentrate on children without direct incentives. And we are preparing for our reprocurement process this summer, where we are looking at strategies like guaranteed minimum spend and obligations to support culturally relevant CBOs. We are reforming our CPE programs. This is a new state plan amendment for our LEA billing option. We are moving our entire our county mental health system from CPE to IGT, and we have moved some of the regional center services that historically had been in a 1915I and 1915H waiver program into our managed care settings. And finally, we are shifting agency defined by who does the work and power by who gets paid by redefining scope of practice, by directly investing in community health outreach workers, doulas, and peer-to-peer programs, including 10,000 new behavioral health coaches with associates level training and preparation. Whew. I'm now going to breathe out. Thank you so much.
Thank you so much. And for those of people who are on the call who might not know just a few of those acronyms, do you mind saying what CPE and IGT are, Alex?
Sorry, everybody. I was presupposing that folks were just like me.
A broad range of people.
Love sticking hot forks in your eye over Medicaid terminology. So, CPE and IGT refer to the term certified public expenditure or intergovernmental transfer. Okay. And they are fancy, fancy ways for talking about how you get at the federal dollar. So if you take that slide I showed you where with children, if you put up $1, that's the right kind of dollar, a public dollar, and you get a federal dollar, there's a mechanism for the getting. And there are lots of ways to do it. Capitation is how the MCOs do it. Certified public expenditure means you spend $1, then you submit the paperwork and you get it back. And intergovernmental transfer means you put it up all at once, get it, and then defend it.
Thank you. And I'm assuming everyone knows what the waivers are to Medicaid. So, but if anyone has questions about that, we can answer that in the chat. So thank you. What an excellent panel. Really lucky to have all 3 of you. Thank you for staying on time as well. And we do have a few audience questions. All of these are for any one of you, so just feel free to unmute yourself and speak. Here's one. How can you use American Rescue Act dollars for further transformation efforts in communities?
Well, I'll start off by saying that Washington is using it to strengthen our IT and data needs, because if we are going to continue to go deeper down the value-based purchasing arrangements, we really need good health, medical, and social data that's aligned. We also, I believe, need to look at how are we going to create more centers for evidence-based social type services. We seem to have those on the medical side, but we need more of those on the social side. And I also think the ARPA dollars, for our state, we certainly have a lot more movement in coverage because we are embarking on a continuous eligibility for children 0 to 6 on Medicaid. These things are really important so that we have more continuity, we create more uniformity, we help families stay in the evidence-based social programs and mix them with the right medical social spend of what they need. And I think to Alex's point, ARPA dollars should be rebasing resources and whatnot for an attitude of everybody needs more behavioral health integration and recovery, not just those that are reaching out.
And not to have to diagnose, I think that's brilliant, that we all need. Alex, were you about to jump in?
Yeah, and I delightfully do not work for elected officials for the first time in my career, so I will get to say some things maybe that others wish they could. As welcome as the ARA funds are and all the stimulus funds are, they are part of a history of serial entrepreneurialism of the political sector that does not fundamentally address the unique entitlement that Medicaid offers children. Many of us in the public sector would much prefer investments in FMAP or sustainable, maintainable ways to develop reimbursement than one-time funds, which leave behind an obligation to sustain services that really require creative investment and things that can be sustained through other mechanisms. So I'm not saying to give back the billions, but I think that they tend to be box checking and not at the kind of fundamental dysfunction of our safety net systems.
Well, so that leads us to another. Were you trying to say something, Dr. Halpin?
Yeah, I wanted to build on Sue's point around the data and information issues. I think that it's one of the things that's really important at present is to really build the capacity of not the public sector or the private sector, but the civic sector that are those that actually serve communities and help communities move forward. And one way to do that is to actually have data systems that are in place that tell us about the health, development, and well-being of children and families. And unfortunately, in the United States, we don't have those. We've spent the last 30 years talking about the importance of the early years in children's development, all the brain development, everything that goes on. But children are basically invisible from the time they're born till the time they hit 3rd grade, unless they have problems. So we miss everything. And so there's an opportunity at present to use some of those that funding to start to build that kind of data systems that we need, that communities need, so that they can have more power, understand themselves, and advocate. And again, from what Alex was talking about, if you're going to shift power and shift agency, you're only able to do that by increasing trust, information, and learning, and you do that by having better data systems to do that.
Thank you. Okay, so we just have about 5 more minutes in this section. One question is, in thinking about next steps toward transformation, what are 1 or 2 key regulatory or statutory barriers at the state or federal level that could be addressed? Anybody?
Well, I'm sure Alex will follow suit here, but I think the current SPA and waiver approval process, because as Alex discussed earlier, we all have to go through our authorizing environments to get permissions. And I think it's time for our federal partners to look at a different way that states are permitted to move further into the transformation journey. I personally think that we need, as Neil said, more of a focus on a life stage approach where we can get longer periods where we kind of lock in families and providers. And so all of these things would need some major change at our federal and state processes.
Yeah, I would go right at sort of business practices of Medicaid that Sue just referenced. But then I would also go at formal scope of practice issues, like allowing for formally clarifying the allowance of reimbursement for the lived experience, developing peer-to-peer and social models built on recovery. Like basically, we are currently using diagnosis-driven identified patient reimbursement models that inappropriately pathologize low-income communities of color to pay for the paychecks of a largely white professional class. This must be confronted. At some point, we have to have the economic benefit of the Medicaid program derived to the population it serves.
Fantastic. Thank you. Oh, Neil, did you want to say something?
Well, one of the things I think would be really important to do to make progress is for CMS and the administration to consider what I would call a kids sim, state innovation model project. There are all kinds of ways that states could be moving things in a direction that aligns resources, funding from silos into different ways of organizing funding. We have, for example, in Los Angeles, a wonderful program called the Hope Street Family Center that provides health and mental health and early care and education, all kinds of services. Unfortunately, and everybody that comes there says, "Oh, this is the best thing that I've ever seen." The problem is it took 11 years to braid and blend and macrame the funding streams together to be able to do that. And, if there was a Hope Street bundle that came from a state starting to recognize that we need innovation in how we organize ourselves and pay for things. So I think having a national learning community around innovation in that regard be somewhat similar to the SIM that was attempted during the Obama administration. That hasn't been all that successful, but actually redesigned in such a way that really helps states take on not only the design challenges, but the design and funding challenges across multiple agencies, because we're never going to get to the kind of integrated whole child, whole population if in fact every state agency is doing their own thing.
Thank you. I think I have a duty to point out that this conversation has been very much child focused. And of course, we all want to focus on children across the life course, but it's important to remember that older adults have lived with structural racism and discrimination their whole lives, and that the heterogeneity in aging and function is largely related to the experiences that they've had and the neighborhoods they've lived in and the food access they've had as well. So I just want to be sure that as we think about transforming, we're thinking also about older adults.
And Sarah, you're absolutely right, but we also have to allow for things like shared savings off of state-run hepatitis C elimination programs. And just like off duals, we have to look at where can we create shared savings and let states reinvest across the lifespan. So we also here in Washington are lifting on the first publicly funded long-term care public insurance policy, and that's going to generate billions, and we need to be able to reinvest across the lifespan and across outside of HHS. So
Absolutely.
Lots of work to do about braiding and blending.
Well, excellent. And so on that note, we're coming back into being on schedule, and thank you so much to the panel. We're really delighted to have you, and I'm sure people in the audience will follow up over time.